Good morning.
Good morning, everyone. Kathy will be joining us shortly, and we'll get started in just a few minutes. Thank you.
Welcome, folks. Just taking a look at who's here. We'll give folks another minute to jump on. Welcome again, folks. I think we might be missing a few people just given that today is election day. I know a few people were worried they might be running late. My name is Kathy Cumming W. I use she, her pronouns. I am the Advocacy and Programs Director at Maine Equal Justice and Chair of the MaineCare Advisory Committee. We'll go ahead and get started with introductions. And I'll try to catch afterwards if other MAC members join. So usually what we do for introductions for folks who are new is I'll go through the list of MaineCare members and alternates where needed, and then we'll jump over to the folks from MaineCare and then come back to any MAC members who we missed. And then if anyone's here as a guest, you can then come off mute and introduce yourself then, or you can introduce yourself in the chat. Again, we'll say our names, pronouns, and either our organization or what brings us here today. And I'll start with Miriam Bashir.
Hello, I'm a public health student over at USM.
Thank you. Nilsa Ayanli.
You'll be coming in late, Beckham.
Okay.
She said it's probably at 11.
Okay. Norma Desjardins.
Hi, good morning. Norma Desjardins from Presque Isle St. Apollonia Dental Clinic, she, her, hers, and on the MAC committee.
Thank you. Catherine Brandt. Jessica Drenning.
Hi, good morning, Jessica Drenning, she, her pronouns, and I am the Senior MaineCare Program Manager with the Office for Family and Dependents.
Jamie Bork. Or Eric Fromberg. Adam Bloom Picopoulos. Or Suzanne Farley. Kathy Dion. Becca Matasovich. Or
Hi,
Kaylee.
Hi, yeah, I don't think Becca's on yet. Kaylee has, I'll be her alternate for now. Kaylee has she, her pronouns, Children's Oral Health Network of Maine. Good morning, everyone.
Vicky McCarty. Rachel Collymore.
Good morning, everyone. Rachel Collymore, she, her, hers, Consumers for Affordable Healthcare.
Sarah Squires.
We cannot hear you for some reason, Sarah. It didn't look like you were muted, but we're not getting audio.
Oh, I thought I saw Sarah. Okay, there you are.
Can you hear me now?
Yes.
Yeah.
Okay. Sarah Squires, she, her pronouns, Policy Director at Disability Right Maine.
Gia Drew.
Good morning. This is Heidi Lester. They, she stand in for Gia Drew at Equality Maine.
Thank you. Susan White.
Good morning, Susan White. I'm here for Home Care and Hospice Alliance, she, hers.
Catherine Hamilton. Leo Delicata.
Good morning, Leo Delicata, he, him, and I'm with Legal Services for Maine Elders.
Sarah Lewis. Laura Cordes.
And good morning, everyone. Laura Cordes, she, hers. I'm the executive director with the Maine Association for Community Service Providers, or MAXPE.
Rachel Dyer. Or Nancy Cronin. David Winslow. Oh. I think that was just someone joining by phone that wasn't muted yet, but just double checking that it wasn't David. Anne Sedlak. Bobby Martin.
Good morning, Bobby Martin, Director of Community Health Innovation and Partnerships for Maine Primary Care Association, he, him pronouns.
Candy Henderly. Teresa Cochran. Or Kristen Goddard. Sarah Lewis, is that you on the phone?
Yes, it is.
Okay.
Yes, it is.
Thanks, Sana.
Thank you.
And we'll pass it over to Maine Care now, and then we'll come back and catch anyone that we missed. And Michelle, I saw you, so.
Good morning, Michelle Probert. I use she, her pronouns. I am the Maine Care Director. Nice to see folks this morning. Would you like me to cycle through the rest of Maine Care? I will pass the baton to Kayla.
Hi, everyone. Kayla Sargent. I use she, her pronouns, and I am the Associate Director of Strategic Planning and Communications at the Office of Maine Care. And I will pass it over to Courtney Platson.
Good morning, Courtney Platson, Medical Director for Maine Care. Pleasure to be with you all today. I'll turn it over to Sana.
Good morning, everybody. Sana Osman, Member Engagement Manager at the Office of Maine Care Services. And I'll pass it over to Becky.
Good morning, Becky Parsons. I'm the EPSCT Program Coordinator with Maine Care. Sarah Fisher, I think I saw.
Thanks, Becky. Hi, everyone. I'm Sarah Fisher. I use she, her pronouns, and I'm the Maine Care Outreach Specialist with OMS. And I will pass it to Roger.
Good morning, Roger Bondison, Associate Director, Division of Operations. And I also manage the transportation program. Pronouns are he, him.
Thanks, Roger. I see Jessica Miller on as well.
Morning, I'm Jessica Miller, Associate Director of Policy at Maine Care, she, her pronouns, and I see Molly Slotsnik.
Hi, good morning. I'm Molly Slotsnik, Chief Operating Officer for the Office of Maine Care Services, she, her, and I'll go to Lisa.
Good morning, Lisa Weaver with the Policy Unit, Office of Maine Care Services, she, her, and I believe Amanda Richards is on from OMS.
Good morning. I just heard my name, but I'm Amanda Mahan at the Maine Osteopathic Association. I'm not from OMS. But I did want to note that Anne Sedlak is on maternity leave and the MOA works with MMA, so I'm happy to be proxy if that's appropriate.
Thanks, Amanda. Is that everyone from Maine Care? I just want to flag that we had a couple of MAC members join. Rachel Dyer, do you want to introduce yourself?
Sure, I put myself in the chat. I'm Rachel Dyer from the Maine Developmental Disabilities Council, and I use she, her pronouns.
And Vicky McCarty?
Hi, I'm Vicky McCarty, and I'm a policy analyst with the Consumer Counsel System of Maine.
And Adam Bloom Pikopoulos?
Hi, Adam Bloom-Pykopoulos, Executive Director at the Alliance.
I'm going to get that right next time, Adam. And
No worries.
Becca Matasovich?
You got Matasovich correct. I'm impressed. Becca Matasovich of the Children's Oral Health Network of Maine.
Anyone else from the MAC that I missed? Any guests who'd like to, I see some folks are introducing themselves in the chat. Anyone who wants to take themselves off mute?
Hi, Rita Furlow, Senior Policy Analyst at the Maine Children's Alliance.
Welcome. Okay. Well, if other folks want to introduce themselves in the chat, please feel free. We'll go ahead and jump into the agenda, and we'll kick things off with updates from the Office of Family Independence, which does the eligibility side for MaineCare. And Jessica, is that you today?
Yes, it is. Ian is out today, so I'm covering that quick update. So I did want to just provide like a brief overall update that officially we have like wrapped unwinding in that we have sent all the renewals to our unwinding population that we were planning to send. So everyone has been given an opportunity to renew that was part of our initial unwinding population. I do have some additional numbers that I can share with everybody, not too specific, and just to point out too that part of the reason for that is that while we're done unwinding and have sent renewals to all, there is still going to be a couple months of just cleanup processing and potential for people to kind of come back. So these numbers won't necessarily be finalized until January 2025. When we've reached the end of our 3-month period post the initiation of renewals for that final batch of the unwinding population. We started the unwinding with around 416,000 individuals. We were able to successfully renew around 335,000 renewals and closed around 67,000 individuals. However, again, like that number is still changing and don't want to settle on one. I think that's important for people to know because they are interested in knowing that some of the primary reasons that we saw for closures were just non-responsiveness in general to the renewals. Didn't ever kind of respond to the renewals that we send for whatever reason. Some others also closed for being over income. As we know, we were allowing people to stay on continuous coverage regardless of changes in income throughout the unwinding. So we kind of anticipated and expected that that would be a larger population of people once we had to finish unwinding that were closing. And then there were other various smaller batches of reasons why people might have closed. They could have moved out of state, they could have passed away. There was return mail. There was a lot of other kind of smaller pieces that we looked at, but there is going to be a broader messaging, coming out in the form of a blog post. And we'll be prepared to present, like I said, more kind of final figures. This really can't be considered final just because we're out of October. We're going to be looking at it 3 months post as well. That was primarily the main update that I had regarding unwinding. And I know that there were some questions as well around some of our phone queue metrics and things like that. So I just wanted to point out that we will be prepared to discuss that further on the December call when Ian can also join us and we can kind of highlight some of our upcoming plans for 2025 as well as a report out on some information from 2024.
Thank you, Jessica. Any questions?
Hear me?
Yeah. Oh, go ahead.
It was an add-on at the end of the provider meeting, and trying to understand the whole process, but is OFI responsible for like when clients call in and they're losing a service? There was just some commentary about what is the average wait time currently? Because in the past, providers experienced 2 to 3 hours waiting when they were trying to provide services directly to clients who were losing access to service. And we're just wondering, what is the current average wait time that the provider line is experiencing? Because at some point, providers were issued a provider line. Is that still in use? And then the other question was just how long is the average MaineCare recipient waiting now when they call in?
Okay, yeah, thank you for those questions. I can take those down. I can try and circle back and get an answer before the next call on some of those averages, but also, yes, to the provider line still being in use and available. I can answer that right now. That line is still an option and is still used. I think that there was some back and forth, and there has been some concern that maybe there's been an overuse of the provider line. We're seeing a lot of calls to the provider line that maybe the people that are staffed on that line are not skilled to answer. For example, if they have questions about their food supplement benefits or would like to apply for food supplement benefits, and that line is staffed by staff only trained in MaineCare who are only prepared to answer questions to providers for MaineCare. There's been some kind of discussions internally around that and how we can best support the needs of everybody in those moments, and making sure that we're accounting for those things. So I would anticipate some like updated, guidance or information around those things, but I will also look into the average times forward. Throw it in the chat shortly.
And a suggestion maybe of like what's best used of that provider line proactively, so we're not, as providers, we're not misusing it too. So like, what's the scope of the line, and this is what it covers. And if you have these questions, call here. Just again, to try to reduce any wait times.
I do believe we have that documented too, and I've shared that in the past, so I can put that also into the chat.
Jessica, when you're working on getting the numbers about the wait times for folks, I think it's important to be clear what's the wait time. I know there's like an initial triage that's been put in place, and in a few folks have mentioned that when they've asked for stats around wait times, that seems to be the number that often gets given. But for people who have a more, it would be interesting, I think for this group, it would be helpful to understand like what happens to a MaineCare member or a person trying to access MaineCare when they call and get triaged. Does it automatically go, for a while it was going to to a different queue if it was just MaineCare, and like that wait time was a lot shorter than folks who had issues with like TANF or SNAP. Is that still in place now that the unwinding is done? And then also, are there types of situations for MaineCare folks where they can't be triaged quickly and have to go into the longer queue? And it would be helpful to know what that wait time is then.
Yeah, and like I said, I think we definitely do want to have like a larger conversation around like the wait times and the phone queue numbers like in general, but want to hold off on that until December when like Ian is also here to be a part of that conversation. And we can speak like more broadly about, like you said, the different like avenues for like people to take calls. And I think most of you are also aware that we had like additional contracted staff to kind of help us through unwinding. And we are decreasing that number. So we do anticipate like some changes in overall wait times, even on the very initial entry phone call, if you will. So we're still looking at that. We're still looking at reviewing what all of that might look like throughout this month of November, and we'll be able to speak to it much better in December.
Okay. And I see Jillian asked if callback is still an option, and that is still an option. Yes. Yeah.
It is still an option, and I believe it's been even expanded so that people are calling outside of hours are getting the option to schedule a callback as well. So sometimes when people would call after, 7 o'clock at night, they weren't getting anything, but now they're getting an option to schedule a callback during business hours. We'll they call on Saturday, that's available too.
Great. Thank you. And then Jessica, one other question that I got too late to put on the agenda for today, but wanted to flag for you all is that there's been some questions around MSP enrollment and how that's going for folks who don't know. MSP is the Medicare Savings Program that was expanded significantly. Well, it was expanded significantly 2 years ago, but then delayed and then officially expanded in July of this year. And that helps people with Medicare, but who are over income for Medicaid, MaineCare, to be able to get help paying for their Medicare costs. You don't have any of those numbers, do you, Jessica?
I could probably get some of them pretty quickly, but we definitely have seen increased enrollment in that group of individuals. And again, we know that we moved an entire population into Quimby from the SLIMB population. So those numbers are just kind of large from the start. And then there are an additional group of members of like new members. If that's the number that you're looking for, I can also try and pull that. It'll take me just a minute.
Yeah, thanks. I think any numbers would probably be welcomed by folks. And just for folks who don't know that program, SLIMB and Quimby are like shorthand for certain categories of MSP, but you don't need to know that unless you're like doing eligibility stuff, but that's what Jessica's referring to. Rachel?
So Ian shared with Cake the initial numbers, like just after the income expansion. So I have numbers up until anyways, I have some that I can share with the group. I'll pull them up and send them in the chat. That way Jessica maybe look at those and then only pull up like new ones afterwards, so you don't have to dig out old numbers. So but I'll drop those in the chat in just a sec.
Thanks, Rachel. Any other questions or comments? Thanks, Molly, for that definition in the chat. As long as we've brought up Medicare, I do just want to flag one thing. I think we talked about this at a previous MAC meeting, but I know we definitely talked about it at a dental subcommittee meeting, that as folks are enrolling in Medicare Advantage programs, for folks who are actually eligible for full MaineCare, who are also eligible for Medicare, sometimes these Advantage programs are actually making it so that they can't access care. We found this came up in the dental world because some people, so we have a full adult dental benefit, but if you have another insurance, it goes to try to get paid through that first. And since very few dental providers, if any, accept any of those Advantage plans, the patient ends up getting stuck in this loop where their Advantage doesn't pay for their dental care, and then MaineCare won't pay for it because they have this other insurance. But for folks who have full MaineCare, like who are eligible for full MaineCare, they probably don't need that Advantage plan because it pays for all the kinds of services that those Advantage plans would pay for. So there may be some exceptions, but if you are working with folks around enrollment for Medicare, it's really important if they also are eligible for full MaineCare to help them understand that, because now people who actually have a benefit that covers them can't get their care covered because they have this other insurance that doesn't help them. So I just wanted to flag that for folks as we move into that time of year where people are looking at those plans. Any other eligibility related comments or questions? Okay, then let's move over to MaineCare updates, and I'll pass it back to
Kathy?
Mr. October. Oh,
Kathy,
go ahead.
sorry, can I just clarify one thing about the last comment you were just making about
Yes.
I don't want to get too far down in territory where I don't know the details of these specific situations, but generally speaking, you're right that MaineCare is the term that we use as payer of last resort. So if any member has any other coverage, whether it's Medicare or a commercial coverage, then the provider is supposed to bill that other coverage first before MaineCare. However, MaineCare does provide wraparound. So if the first coverage either denies the coverage, won't pay for the service or only pays for part of the service, MaineCare will come behind it and pay whatever is left over.
That's interesting, Molly, because it was actually MaineCare staff who brought this to the dental subcommittee as a problem, and we're saying that people are not getting their care covered because of this.
And I wonder if the disconnect is with that what I just said will only happen if the provider bills it in such a way that MaineCare gets that bill a second. So maybe we'll take
I
it
think,
back
Molly,
and
I
see.
think the problem is that most, if not all, dental providers in Maine don't accept Medicare.
Mm-hmm.
And so, and certainly like a lot of the providers who have been engaged in our dental subcommittee work and accept many of the MaineCare patients. And so they can't bill it to Medicare because they don't accept Medicare. And so then it can't get, so that's
Got
a
it.
blue flag.
Okay.
Thank you, Molly.
Okay. Thanks for raising it.
Yeah, it is an issue, at least for dental. I don't know if it's an issue for other areas, but
Yep.
it's hard to see people who really need that care not be able to afford it because of this catch that they're stuck in.
And I'll just add, I think part of that problem is partly because Medicare has not traditionally covered any dental. It's new that Medicare Advantage plans are starting to cover dental, but it's all over the place, right? So it's not something that dental providers have traditionally been in a position to even take.
Mm-hmm.
So you're not going to see a lot of people starting to pick up new insurance plans when the system is already saturated, I think.
Thanks, Becca.
But thank you very much for that clarification. All right, so I'll pass it over to Michelle now for updates from MaineCare.
Great, thanks, Kathy. As a late add-on, I will make an eligibility related comment, which is just to remind folks that, especially for the people who have just gone through unwinding recently, we're still in a period of 90-day redetermination. So if somebody comes to you and says, oh, I missed it, I didn't know, now my MaineCare has been terminated, they're within that 90-day period, they should still submit their information to OFI. And if they do so within the 90 days and they are eligible, then they will be able to get covered without a gap in coverage. So that's just a good thing for all of us to remember. All right. I did want to share, I think we talked about this at the last MAC, but we reinstated copays as of October 1st. That was because of the provisions that were associated with the pandemic through the American Rescue Plan. Some of those provisions to exempt copays had already expired, and then additional provisions expired for 10/1. And so as a result, we have reinstated many copays. Separate from the pandemic and American Rescue Plan, we had a bill where we did permanently discontinue copays related to behavioral health services. So we took away those copays on that same October 1 timeline. I will say that we've received a lot of calls and feedback and concerns, especially around pharmacy copays to our pharmacy help desk. Not that surprising when you recognize that the way pharmacy works is a little bit different from the rest of medical care, where like folks are usually paying for the service and receiving the medication right at the same moment. And this has been a good reminder for all of us that even though none of this is new compared to what we did pre-pandemic, it feels new to a lot of folks, either when they're new to MaineCare, we haven't done something for a number of years, or if you think about the pharmacies, there's probably a lot of new pharmacists and a lot of people who are working in the pharmacies who were never around when we used to have copays. So even though it's a return to previous policy, it can feel brand new to folks. So we've been having a lot of internal conversations and been working on our messaging to members as well as to providers, especially pharmacists, to help smooth this transition. It's good for everybody to remember that there are protections in place, both at the state and federal level, to prevent the copays from being, it's hard to talk about this in the right way, but I'll say too burdensome for members. So at the federal level, there's a cap that is in relation to a member's income. And so we need to comply with that. And if somebody across services is hitting that cap, then they should stop being charged copays. In addition to that kind of federal cap, service by service, we also have some limits on daily and monthly maximums, and this is all intended to help protect the member. So we're reminding folks about that. It's also really important to remember that if a member is unable to pay the copay, a provider is not allowed to deny the member services. And so this has been something that we are reminding providers of as well. We have been receiving a lot of requests for a quote waiver of copays. That is not something that exists. If in the moment a member is unable to pay a copay, they should say so. And again, they cannot be denied services. And if that happens, like, we want to know about it so we can follow up appropriately and everything else. But there is no provision that allows us to say, Michelle Probert never has to pay a copay. That's that there's no process or allowance or authority for that. So I think we have a guidance document that Kayla will share. And again, there's been messaging that we've sent out around this, but we appreciate that this is a big change, even though it is prior practice, and it's a big change for members as well as providers. And so appreciate your patience and help as we reacquaint ourselves to this. Any questions or comments on that front? All right. Norma?
So I'm just going to be very honest here and mention that I don't know a lot about the history of the whole copay thing. And so I think it might be helpful. I don't know if I'm the only one, but if there's somewhere where I can learn more about why some sections have copays and some don't, and what the, I don't know if we'd call it usages of different benefits for where there are copays or where there aren't. But anyway, in the dental world, when somebody has a dental insurance, for example, or like a private dental insurance, there's always some sort of copay or deductible or something. And so I'm just curious about the whole history of that. But we don't have to take up time right now, but maybe I can learn where I can find out where I can learn more about it.
Sure, and I will say that we can absolutely be helpful in terms of what the copays are, what services do and don't have copays, and potentially when things have changed in different areas. It is not always so easy to, we don't always have access to rationale from especially previous administrations for what services, like in some cases there might be like regulations that impact a decision, but we are not always able to explain rationale behind certain choices that happened in the past, if that makes sense. So we have taken some, I'll call them piecemeal steps over the past few years, for example, to be more consistent with our waiver of copays for primary care. Some primary care, it was waived, but then others it wasn't, and that didn't really seem to make sense. And again, also aligned with what has happened with Cover Me and Bureau of Insurance around waiving of copays for behavioral health services. So I think we've made what we think are some good changes and progress in copay policy. However, we have not performed a thorough review and analysis of every single area of copay to say, do we think this is appropriate, or is this providing the right incentives? So we are going through a process aligned with a department bill that passed to enable us to simplify our copay approach. So we are doing more of a review in that regard. Part of the interesting dynamics with Medicaid that I don't think are true with other payers is you've got this trade-off between because there are these caps, and the caps are there for good reason to protect members who are largely low income to begin with. But when you have these caps, that's more uncertainty for providers about whether or not they're going to be able to charge a copay to a member. And if you need to provide the service, regardless of whether the member pays, then the provider can assume that cost. So it's a tricky dynamic. And so ideally we would be, kind of setting copay amounts where we do not think it's going to run into those caps for members so that they're more reasonable amounts, right? But then on the other hand, it's an amount that is more predictable, both so members have an easier time remembering what the obligation is, and so providers have more certainty that they can charge this copay amount and they're not always going to be running into these caps that can make it very frustrating to try to navigate the system. I don't know if that was helpful, Norma, but those are some of my own thoughts about the complicated world of copays.
Yeah, thank you. Yeah, definitely complicated. Thank you.
Any other questions about that? Okay.
All right. Thanks, Kathy. I do have a couple other updates. Just a general reminder that we continue to plan for the reductions related to removal of the service provider tax for January 1. I've heard that there are some questions. If providers or anyone has questions about those changes, Kayla, I don't know if we settled on an email address that those questions should go to, but we had an initial FAQ, and if there are other questions coming up that are not addressed in the FAQ, then we will update that FAQ. The general talking point, again, is that where we have the service provider tax clearly documented, we are removing the service provider tax from the rates.
Michelle, I'm putting the previous e-message with a link to the FAQ in the chat for everyone. And we did direct folks to their provider relations specialist with questions. And I believe we're still considering whether there would be an alternate way to submit questions.
Okay, thanks, Kayla. And lastly, I just wanted to acknowledge that for the past couple of years around this time of year, we have started our annual conversation about our rate determination schedule for the calendar year. We are trying to be mindful and thoughtful about interaction between that plan and also budget planning for the year. And so we're a bit delayed this year with that process, but I think that it is appropriate, again, to make sure that we're aligned, recognizing that there's absolutely interactions between rate determinations, implementing those rate determinations, and the budget process. To Jillian's question about the reduction in revenue due to eliminating service provider tax, so there were budget initiatives that were part of the budget that passed last session that I won't lie, it gets pretty confusing because there's lots of different accounts and revenue accounts, and So it's not straightforward, but it is those assumptions around changes in revenue and expenditures are captured in those budget initiatives that are publicly available and that were part of last session's actions.
My question was, did this have an impact of, why some rates are frozen, or was it really just the expansion? Because it seems like it was significant revenue that was coming in on the 2-for-1. And I just wondered, because some of the services right now that we're doing rate setting, there's no money to fund it in the budget. And I just wondered if this service provider hit really impacted, the budget forecast, or if it was more just expansion exclusively that kind of, I don't read the budget things. Maybe I should, they're kind of over my head, but I was just interested to know, because it seems like that was quite a bit of revenue if you compiled it on the 2-for-1 side, but.
Sure, there are absolutely lots of different inputs and dynamics to the budget. I will say that there was a lot of conversation on what to do to account for the repeal of the service provider tax. Part of that was these reductions to the rates as a result. And then we also passed different tax changes in the last budget, which have helped on the revenue side. And I think that is it for my updates. Kathy?
Great, thank you so much. And I'll send out those links as well to folks.
That wasn't for my updates, but I forgot that Courtney has one of the updates that was on my list, and so I did want to turn it to Courtney to.
Oh, okay.
For exciting updates. Sorry.
No problem. I just wanted to share, we were really excited. Maine was chosen as one of 6 states to be a part of the Medicaid and Corrections Policy Academy. The work that we're undertaking for the Justice Initiative includes the Consolidated Appropriations Act, Section 5121, that's specific to juveniles that will be implemented next year in 2025. And the 1115 reentry waiver is a much bigger, broader effort that will really take place over the next 5 years. And we're really excited to have this national training and technical assistance to support Maine in this effort. And we've had a lot of really wonderful affirmation of our process and our our cohesion across DHHS, the Department of Corrections, and the jails. We've had really wonderful partnerships, and people are really motivated to make this work to improve the health outcomes of people who have been just as impacted. So just wanted to share, we're really excited about that opportunity. Our team just was in DC last weekend for our first in-person training, and the academy will run for the next 6 months. So happy to provide updates as we get closer and as we move through these various initiatives. So if anyone has any questions, I'm happy to answer them.
Thanks, Courtney. That's exciting. All right, then let's move to the rates system updates. And let's start with the MaineCare folks. Amanda, are you here?
Sorry, yes, I was late. Sorry about that.
That's okay.
Yeah, so high level last week, we posted the therapeutic foster care final draft rates and comment summary. We held the revisions for nursing facilities, revisions to the originally proposed draft rates and models, and posted the presented materials. We also posted the March forum comments with department responses. And then this week, tomorrow, we have 2 public forums. We have the Certified Community Behavioral Health Clinic forum to present the draft models there. And then we also are presenting revisions to psychiatric residential treatment facilities, also known as PRTFs. So those forums are both tomorrow. That's a high level update, but that's big stuff. If anyone has any questions?
There's a question about how long the comment periods on CCBHC and PRFT will be, and I don't know what those acronyms stand for.
I don't know. Well, the comment periods generally are about 2 business weeks, 10 business days. That's generally what we allow. So I don't know if that was decided or went out in the notice yet. But that's generally the time frame that we allow.
Thank you. And the acronyms are described now in the chat. Thank you for that as well. Any other questions? All right, Laura, I'll pass it over to you for updates from the subcommittee.
Thanks. Good morning again. So the rate system subcommittee last met on the 28th of October. We tend to meet on the last Monday of the month. So our next meeting will be the 25th, and I'll put that in the chat. Meetings are open to anyone, certainly from the MAC, but all stakeholders, members of the public. And, you know, we continue to serve without a co-chair. That was something that we all, I think, both for the MAC and our subcommittees, we're all looking for some volunteers to support our work. So if anyone is interested in doing that, especially with the legislative session coming up, it'd be great to have a co-chair. So please consider that. We are working to develop a survey that we hope to push out this month to get feedback for the department on the current rate setting system. You know, maybe even just outside of the fact that there is a potential budget deficit and some concern about actually funding the system of both determining the rates, let alone funding any rate adjustments that would come from those determinations. So when we were working on a pretty straightforward survey that we would push out to MAC members and hope that there may be some support from the department in pushing that out, and certainly from all MAC members to pushing it out to your networks. And we're hoping to do that this month. So look for that likely next week. And, you know, I appreciate Director Probert's comments about the upcoming schedule for the 2025 rate determination schedule. And that is, you know, I think as you make those plans, it would be helpful to keep coordinated with the rate setting system subcommittee so we can do our due diligence in providing feedback around that schedule, even if it is a schedule that says we, you know, would, if we have funding, we'd like to do A, B, and C. If we don't, you know, so we're looking at that as we're headed towards the end of the year and wanting to be available to coordinate and provide that feedback on any schedule you would propose and for any TAP meeting that you might have for us to share any input on that schedule for 2025. We also discussed the service provider tax, and you know, I think from our group, we didn't have so much questions as kind of concerns and wondered about where to bring those into the department. So maybe it's a letter or a meeting request with you, Michelle. And the concerns, I would say, are kind of in 2 areas. One was identifying, some providers have identified rates that were included that they believe were maybe erroneous for their inclusion in the service provider tax repeal list. They're basing that on the fact that they have correspondence and refunds from the main revenue services saying you were not required to pay tax on these service rates. And so that puts them in a position of having not, let's say, for the last several years, paid a service provider tax. So this is, and in good faith, not paying it, having a notice from, you know, correspondence and a refund. from Maine Revenue Services. So moving forward with that service rate included in a repeal is a 6% reduction in the service rate at a time where access remains important across the board for folks. So, how to highlight those. I know some members did that through the waiver comment period that were adjusted, but for, let's say, rates that were outside of any MaineCare waiver, is there a way to comment outside? And it didn't seem like a provider relations specialist was exactly where to go. So, I think for providers that have reached out to me, I will tell them to coordinate, and send correspondence with you and perhaps MRS. But if you had any, additional direction for folks, because it's less of a question and more of a large concern about seeing a potential 6% reduction in rates that they were under the impression that they were not needing to pay a service provider tax on. And then I just have two other items I would say related to service provider tax. The other concern that folks raised was in the notice not having a actual new amount for that rate. So X rates are included in the service provider tax repeal, but providers feeling like they wanted just to make sure their math was the same as the department's. So for budgeting purposes, that they knew going into January that they had, the right rate minus 6%. And I think that is tied to another concern that we had from the committee that I just wanted to bring today. And if you can respond, that's terrific. If not, I thought I saw something about maybe the December meeting being moved. So I thought, well, it seems timely now to raise, concern about just COLAs and the calculation of a rate that had a service provider tax repeal of 6% and the potential COLA. So these kind of merge in how is that calculated and what is that amount? So going back to do we have the same amount as the department has? And raises kind of another set of questions and about COLAs and the timing and what does that look like for the year ahead? So when will the new rates be posted? And what is the COLA percentage? I know the last budget or our current budget has a 2.54% COLA budgeted, but the minimum wage increase likely would be higher than 2.54 for those rates that need the labor components matched to 125% of minimum wage. And then maybe a couple other questions relating to the COLA. Is there any concern that there's not enough funding in the current budget to support anticipated COLAs for January 1? And I think that last piece is how is the, for the service provider tax repeal rates, what's the formula? Is it 6% reduction from the rate and then the COLA, or is it the COLA and then a 6% reduction? So I think that's it. I'm going to put in the chat. And if we do have time, and Director Probert, if you have some responses to that, I think it'd be helpful for our committee and other members. Thanks.
I can respond to some of those items, Kathy, if you want me to do that now.
That would be great.
I wasn't doing a good job of taking notes. So Laura, if I forget something, you can say.
Understood. Thank you.
First, I'll just acknowledge that I think it's safe to say it's kind of there's been a sort of fraught and often confusing history going back many years on the service provider tax and what is and is not subject to the tax, and over the years kind of different practices of Maine Revenue Service deferring to the department or vice versa. So in recognition of that history, we've decided that it really made the most sense to focus on where we have documentation, clear documentation that we have built in service provider tax into the rates, and where we have that documentation to remove. And so that is where we landed and what we have communicated. for additional questions and concerns, again, you can pass concerns along to me. We can also circle back, Kayla, to see if we need a more general mailbox, if there are specific questions. The question of when are we communicating what those rates are, I think, as you also noted, Laura, is absolutely tied up with the question of the cost of living adjustments. I thought that okay, yes. Thank you, Kayla. I was going to say, I thought that our FAQ did address the kind of order of operations question, and it did. It is in there that we would apply the service provider tax removal to the current rate, and then COLA is a second step. So thank you for that, and that we will be providing what the new amounts are 30 days prior to implementation, which is what we're required to by law as well. And in terms of cost of living adjustments, timing, budget, et cetera, I will say that we are actively having those conversations so that we can meet that 30-day notification requirement, but I don't have additional information at this time. Was there another component of your questions and comments that I missed, Laura, or did that mostly hit them?
I think it mostly did. Thank you. And thanks, Kayla, for sharing that. I'll remind folks it's in the FAQ.
No problem. Thank you.
Thank you all. I want to ask a quick question about the agenda because I've had a couple requests about people who were here for the non-emergency transportation conversation, but that we're a little behind schedule. So I'm wondering if it's okay if we do that next and then do the outreach presentation. Sarah Fisher, I'm kind of looking at you and I'm trying to see where Roger is.
That's fine with me if Roger is good with that. Thumbs up from Roger.
Great. Okay. Sorry. Thank you. So then let's do that. And Roger, I'll pass it over to you.
Thank you and good morning, everyone. I've got a slide deck I'd like to present to go through non-emergency medical transportation, a little history, and current day operations. All right, are people seeing the screen?
Yes.
Okay. Did that right. So the current brokerage model began back in August of 2013. And prior to that, the department was using what was referred to as regional transportation coordinators. And these were primarily community action agencies and a handful of companies like Western Maine Transportation out of Lewiston, Auburn, Regional Transportation Program, Westward Portland, and ARTS up in Presque Isle. And back in history, prior to my coming on board here at MaineCare, the department was applying to the Centers for Medicare and Medicaid to acquire a higher federal match for the transportation program in effect at the time that we call the fee-for-service system. And in that effort, CMS found several issues with the program as it was functioning then. And I'm just going to go through a handful of these for context. So the federal government found that payments were not going directly to the entity delivering the trip. The federal match could only apply to the actual trip costs and not the administrative costs, and our rates were bundled at the time. And the RTCs relied heavily on volunteer drivers and reimbursed them for mileage costs, but the federal government required that the state pay those volunteers directly, which we were not doing. The RTCs reimbursed members and friends and family for mileage expenses, and these persons did not qualify under the fee-for-service program as a direct vendor. Therefore, these costs were not allowable. The state failed to demonstrate that the RTCs were using the most cost-effective trip available, and the program had not been competitively procured. And also, the state didn't demonstrate that it had criteria to actually qualify folks doing transportation. Additional issues were that we didn't have any data to actually assess program quality. And all I can say is that when I came into the office, anecdotally, the staff was receiving a lot of complaints, but they weren't tracking complaints, types of complaints, timeliness, and that kind of thing as we do today. Some have said that the old program was better. I still hear that comment from time to time, but there's really no data to support this claim one way or another. What we can say is that when the brokerage model was introduced, there were huge gaps in service that were exposed, particularly in our large rural areas. The one that I recall very vividly was wheelchair accessible transportation, and it was lacking or virtually non-existent in a lot of areas of Maine. So to bring our program into compliance with federal rule, we adopted what we call the at-risk brokerage model, which is in effect today. And this model was the only option that offered full federal match and a high level of program oversight and accountability. So that's a little bit of the history of where we were and why we are where we are today. So we have currently 3 brokers that are providing transportation. They each cover different regions of the state. Those brokers are MotiveCare, Penquist-Cap, and Waldo-Cap. And fun fact, Maine has the 5th highest utilization of this program in the nation. And this is from a report from CMS to Congress. And just for your knowledge, Alaska has the highest utilization, followed by Arizona, Minnesota, Wisconsin, and Maine. I don't know that I understand why we have the 5th highest utilization. It may be because we're the oldest state in the country. That could be one reason. So last summer, we issued a request for proposals, as we're required to do because we have to competitively procure these services. MotiveCare was awarded contracts for the entire state. And as some of you are aware, that decision was appealed by the other 2 brokers, Penquist and Waldo-Cap. That appeal was denied in April of last year. Penquist, and we're still awaiting the court hearing. They've taken it to court. So I believe oral argument begins sometime this month. But we probably won't have a decision from the court probably well into next year. So that's where we stand with the procurement process. Covered services with this program include generally, if the service is in the MaineCare Benefits Manual or MaineCare or CHIP, the person being transported must also be receiving the covered service. We do allow escorts in certain circumstances. The provider and the facilities that we are transporting to must be enrolled with MaineCare. We do transport trips to pharmacy. We do cover expenses such as meals and lodging for long distance trips. Out-of-state travel must receive a prior authorization from MaineCare. And we do transport to enrolled day program facilities and supported employment for disabled persons. Things we don't cover are ambulance services, including if a member needs to be transported by stretcher even if that trip is not an emergency trip, that does fall under the purview of ambulance transport. We do not generally do transportation for individuals in nursing facilities or intermediate care facilities, primarily because they have transportation as a component of their rate. We do make exceptions. For example, if a nursing facility's vehicle is broken down and in need of repair, and it's going to take a week or two, we can spot them for the duration of their vehicle repair. Also, coming out of COVID, there was a significant labor shortage and some facilities just couldn't get a driver. And so we helped out in that circumstance as well. Other services we don't cover is transportation to visit a sick family member. We challenged CMS on this, and they said that the person in the vehicle has to actually be receiving the service. So we had to discontinue what we were doing this. And again, transportation where there's no actual client transport. This happens when a broker dispatches a trip to a company and either the member doesn't show up or the trip was canceled. The broker cannot reimburse the transporter for that trip. We don't do trips to grocery stores, museums, community events, and as I mentioned earlier, unenrolled facilities or locations. The transportation types that we do, public transportation, which primarily in Maine are buses and ferries, and on occasion down east, the Downeaster to Boston is utilized. The brokers do provide mileage reimbursement for friends, families, self-drive. They utilize taxis and airlines. We don't use air travel that much, but it does occur. What we refer to as an agency vehicle is basically one that's operated by a public entity or a private nonprofit or a private for-profit company. And of course, we do wheelchair transport. A little bit of information on performance of the program. I updated this slide. I had an earlier version of this. And what I did here was I took each of the regions served by the 3 brokers and I averaged out their performance over these 3 months. And some of these key performance metrics that we look at: call center service level. There's basically the number of calls answered within a minute. So 90% of the calls have to be answered within 60 seconds. No more than 5% of the calls can be abandoned. And generally what that means is a member gets tired of waiting and they hang up. The number of missed trips we track, and the contract metric there is no more than 1% of trips should be missed. The complaint rate, the metric there is no more than 1 complaint for 100 trips, or 1%. You should be below 1%. On-time percentage currently stands the contract requirement at 85% or better. And as you can see, the on-time percentage is hitting 90% or above. 4 or 5 years ago, we were probably averaging 85, 86% on time. So this metric has improved quite a bit. And we do track the number of trips per month. That's not a requirement. That's just, it is what it is, depending on the regions covered and the population, et cetera. So that's a little bit of how the system is working today. We also track complaints. This chart shows you the complaints called into MaineCare member services over the years. And you can see back in 2013, when we switched over from the old model to the new, many complaints were called into MaineCare. But over time, those number of complaints have come down. They did bump up a bit in 18 and 19. 19, that probably had something to do with expansion and more people coming into the program, but it has since gone back down. to less than one complaint a day coming into the net team. The types of complaints that we receive, most of them, as you can see on this graph, probably 65% plus or minus, include missed trips and late trips. Another significant part of the complaint picture is mileage reimbursement. Sometimes folks aren't paid timely. Sometimes they don't like the forms they're being used, or they'll challenge the amount of mileage that they travel. Their odometer says one thing, but the broker software says another. Those kinds of things. A smaller number of people complain about phone service. Generally, this is customer service rep who was rude to a MaineCare member. I believe every broker now is recording every phone call that comes into their center, so there is an ability to check on these complaints to see if an employee was rude or unprofessional. Driver complaints, again, can be anything from driver driving too fast, the heating system wasn't working, or the AC system wasn't working. Actually, that's vehicle dissatisfaction, that the car was not clean or some systems are not working. The address issue is one that shows up, and this is really not the fault of the brokers. As you'll see in a minute, brokers have to go by the address of record in our system, and that is because brokers are paid based on where a member resides. So if a member moves from one region to another, it's covered by a different broker, and they don't make that change with the Office of Family Independence, that might lead to a denied trip. Some general questions to close out this presentation. These are questions we get fairly often. Is the state looking at improving transportation for persons who are not eligible for MaineCare? Yeah, we are having a lot of conversations with our colleagues at the Department of Transportation and other services. But when it comes to MaineCare transportation, it can only be used for services covered by MaineCare. That is a limitation imposed by the federal government. And as I mentioned about the address, the member or someone authorized on behalf of the member must make that change to the Office of Family Independence. Brokers can't change it. They have to go by the address of record. And sometimes we get asked, why aren't brokers held accountable? They are held accountable. When we get complaints from folks, however they come to us, we contact the broker, we research what happened. And if it's a missed trip, the broker couldn't find a driver. We work with a broker to correct that situation. And if there is consistent failure over time, we can put the broker on a corrective action plan, which we have done in the past, both with ModivCare and PenquisCap. So if a broker is not responsive to addressing any issue, whether it's from a healthcare provider or from a member, they can contact member services, and member services will relay that complaint to my staff, and we will follow up both with the person issuing the complaint and with the broker that is tied to that complaint. And as I mentioned earlier, ModivCare was awarded the contract for the whole state, even though that is currently in dispute. But we did get questions from folks, what happens if ModivCare takes over? What happens up in our little town that ModivCare may not know about? Well, ModivCare currently serves several rural areas in Maine, including Aroostook and Washington and several others, with very large rural areas and small towns. So assuming one day this transition happens, I think the company's prepared to address these concerns about folks who may be living in other areas of the state not currently covered by ModivCare. A couple of other questions. that have come up from time to time, because we are still dealing with a driver shortage, although it's much better today than say it was a year ago. The pandemic did cause many drivers to either retire or move on to other types of work. Demand for transportation came way down during the pandemic. Some drivers got laid off, they moved on. Others didn't dare to drive for fear of getting sick. So those are some of the factors that reduced our driver pool. And wages were a factor for a period of time, but I think this has largely been addressed. I think the other part of the labor shortage is that my generation is retiring in large numbers, and there's just not enough people to fill the job. And so that affects transportation as it does healthcare and several other industries in Maine. And then I think this is the last one I addressed, that some brokers are not open after 4:30, but we don't close until 5 or later. Brokers are contractually required to arrange rides 24/7, except on state holidays. So if anyone hears about this, all they need to do is contact us or member services, and we will look into that, though I don't recall getting a complaint about this specifically for quite some time. But if it does happen, we will certainly address it. So with that, I'll be glad to entertain any questions.
Roger, Jillian has a
yes.
few questions in the chat, so I can read them out one by one. I'll make sure I got them all. So Jillian's first question is, do parents get to go with kids? What if mom has 2 kids and the trip is for one of them?
Yes, if that's planned ahead. So for example, our policy stipulates that if mom needs to bring a child because she can't find a babysitter, etc., call the broker in advance and request that. What happens frequently, though, is if a driver shows up and the parent is expecting to be able to bring that child without calling it in advance, the driver will likely refuse it because that driver may have every seat filled. So it's important to do that ahead of time. So the answer is yes, but not every time, and it depends on who else is booked for that trip.
Can I follow? This is Sarah Lewis
Yep.
from Maine Access Network, and I just wanted to follow up on that really helpful question. Is there a written rule as to how far in advance the call needs to be made? A lot of us in Southern Maine use a nonprofit. We rely on Maine Association of New American Transportation, which is excellent. And they have very clearly written rules in all languages as to how late is too late to call in a ride request or an edit to your ride. And that's something that's not easily accessible. And I'm wondering if that could be improved.
Well, there is by policy a 2 business day requirement.
So a mother with children would have to know 2 days in advance if her child care fell through. That's problematic. And I'm wondering if there's something we can put a pin on that to work on, because that's not realistic.
Right. Well, above and beyond that, the broker needs a couple of days to find somebody to do the ride. So if mom calls a day before, and if the broker can, if that particular trip is not booked solid and there's room, the broker could make that change. But if that trip is filled with other MaineCare members, then not likely.
Okay.
I saw Jillian had other questions in the chat, but other people have since raised their hands. So Roger, I'll let you go with the people who've raised their hands, and then Jillian maybe can raise your hand too. And
Okay, I see a hand from Maine Equal Justice.
Hi, Roger. My name is Alex. I'm sorry, I could not change my name on the Zoom screen here. Thank you for the presentation. I wanted to ask a question about assistance for folks with mobility challenges or other disabilities. This is a question we get a lot, and a concern that comes up. And we've gotten some varying responses around whether or not a driver can assist someone, if a car if there's a requirement for main care to send the right type of vehicle, if someone has a mobility challenge, et cetera, et cetera. So, and then there was something that got raised the other day by one of the brokers around there being potentially like 2 waivers or 2 contracts in Maine that makes that more complicated. So maybe you don't have time to go into that right now, but I would love a little clarity on the policies around supporting folks with disabilities and mobility challenges.
Well, I'm not sure what you're asking me specifically, but we are required to provide wheelchair transportation. Drivers can provide some assistance to hold somebody steady, for example, if they're ambulatory and they need a little help getting in and out of the vehicle. One of the things that I see fairly often is a request to go into somebody's home and actually help them in a wheelchair, that kind of thing. And drivers will not go into somebody's house. That it's door to door. It's not going into somebody's home to provide that kind of assistance. So the driver can provide a little assistance to hold somebody by the elbow, to hold them steady, that sort of thing. They can help them with the wheelchair get into a vehicle, or they're supposed to help them. I'm not sure, though, I'm getting to your question, but off the top of my head, those things are what come to my mind.
Okay, that's helpful to know because we do hear a lot of concerns that that's not happening for folks. And again, I don't know which broker this is connected to, so I'm not trying to ascribe blame to anybody, but that I totally understand that people cannot actually enter someone's home. That makes sense. I guess the other follow-up would be, is it the same 2 business day policy if someone requires a care attendant, so really does need help getting in and out of their home or in and out of the vehicle? Do they need to make that request within 2 business days as well? Or if there's space similarly, could someone come along to help?
Yes, that 2-day business requirement is necessary for that as well. Because if somebody does need, we call it an escort, the broker has to plan ahead to make sure there's enough room in the vehicle for that escort. Because again, if the driver shows up in the driveway and he or she doesn't know there's an escort coming and they've got that vehicle booked with other main care members, then there won't be any room. So there has to be some time for the broker to find a transporter, and then B, notify that transporter that they have to make sure there's enough room for an escort or care attendant, as you said. But I would further add, if you hear of complaints of the nature you were talking about, if you contact me or my staff, the more specificity you can bring to that, the better. So when I say that, I mean, if you have who the broker was that assigned the trip, preferably if you know the name of the transportation company. But even if you don't know that, the main care member's name and ID and date of the incident, then each of the brokers can research which transporter had that trip and take appropriate action. And that's the thing we got to keep in mind when we're dealing with complaints. Even though we hold the brokers accountable for that, they're not actually doing the driving. They hire companies and nonprofits to do it. So the more specificity that comes with a complaint, the more the broker can pin down who actually transported that member on that day, and was there a failure of service on the part of that transporter. So that's why we ask for specificity, because it makes it easier for the broker to figure out who did what, when, or didn't do something that they should have. So if you hear those things in the future,
Thank you. We will do
Yep.
that. And I'll reach out to you because one of the brokers told me that their drivers are not allowed to help people in and out of the vehicle or not allowed to touch people. So maybe that's a clarification we can work on. I'll let
Yep.
you go ahead. I think Rachel might be next.
Yeah, I will. Let's let Rachel and Jillian go, and then we'll have to stop because we still have a few other agenda items for today.
Great, thank you. I was wondering if you could speak a little bit to what the Non-Emergency Transportation Administration Program really does around educating members about dealing with complaints. You know, I'm talking about people with developmental disabilities, many of whom have limitations with communication and understanding, have difficult negotiating like online or not online, I'm sorry, on the telephone, like, you know, systems, we are press 1, 2. So when people have trouble with transportation, they sometimes have a lot of trouble fixing it. So I guess that's one thing. And I'm really surprised, I mean, from what I hear from people, by there being such a small number of complaints, which leads me to wonder whether people know how to file them. You know, I mean, a lot of the people that I'm talking about are people who receive other types of services and often really fear retaliation for complaining about things. So I'm concerned that people are not, that you are not hearing about the people who are waiting in the cold for 3 hours because the ride didn't show up, or a person whose ride didn't come at all, and that the person at the doctor's office had to figure out how to like deal with this because this is I'm just surprised by I'm really surprised by those numbers. And I think that having people have an avenue that is accessible to them to talk about their concerns is really, really important, particularly, and I don't have a pony in the show about who does the the arranging of rides, but Modicare has a terrible reputation, like nationwide. Like my colleagues in other states, just have nothing good to say about exactly those kinds of things, about the timeliness, about the safety of people, particularly of people who have who maybe can ride independently, who don't need help getting in and out of the car, but are going to be challenged if anything doesn't go according to schedule. Thanks.
I'm not sure I'm going to address your question. The number of complaints you saw on that chart are not the total number of complaints. Those were just the complaints called into member services. The brokers have their call centers, and they record every complaint that comes in. And so there are literally, if you figure roughly 2 million trips a year, and let's say it's 0.1%, it's still going to be hundreds of complaints. So, and that's reflected on their complaint log. So I wanted to assure you that that graph you saw is just what comes in through our member services. It is not counting the complaints received by the brokers. So when it comes to voicing complaints, there are a number of ways people can do this. They don't need to go to the broker. They can come directly to MaineCare Member Services. I'm not sure what the issue is with filing complaints to brokers, but if there's any, there shouldn't be any retaliation on the part of a broker. If that is occurring, we need to know. And that's all I can say about that. That can't happen. So anyway, I'm not sure I got to the heart of your question there, but there's all kinds of ways to submit complaints. There are instructions in the MaineCare member handbook. We have a website. Generally speaking, each of the brokers has it on their website, how you can submit complaints online. All kinds of ways. People can call an elected official. We sometimes get them that way.
Who would be the best person to reach out to if like a group of people wanted to talk with someone about that, to learn more about the best way, what the most effective way to do that from,
Yeah, just have them contact me. And then we can have a meeting, we can set up a forum, whatever,
Great.
whatever,
Thank you.
whatever way you want to do that.
Thanks.
Okay, real quick, Jillian, and then I see Michelle.
I think a bunch of mine got answered in the chat, so I'm looking. My only clarifying question here, and thank you for clarifying the complaints, because I thought the number was pretty low as well, because just internally, I think if we shared them adding up, I thought ours would probably be around that for the year. So thanks for clarifying. But and just a statement that yes, internally discussions around, say, our 1,500 members, there is concern about mode of care over KVCAP, Penquist, just historically, that, you know, my teams are fearful that the rides aren't going to show up. But going up, my only question was, you said 24/7 access, and is that Monday through Friday, or does that include weekends? Because I've always wondered if weekend rides are provided if there are facilities that are open for care on the weekend.
Yes, should be. Absolutely.
I didn't know that. So,
Yep.
because we have some center-based programs and I wanted to expand to the weekends, and staff said, well, there's no rides. And so that kind of opens that up.
Right. No, if it's a main care billable service and the facilities enrolled, brokers are responsible for getting people there.
And my only other comment above was just like vetting the rides when they're subbed. Is there some sort of like audit practice to make sure these are like reputable? We've just had some bad experience, and I think I talked to you about this years ago, with people with criminal records giving our clients rides, and we didn't quite know how it happened until it was becoming a crime during the ride. Just how are those monitored? Like the performance of staff specifically, like how do you make sure they're vetted and reputable and safe?
Every driver and every transportation company every 2 years must go through a criminal background check. That includes national and state sex offender registry lists. It includes reviewing driving records at the Bureau of Motor Vehicles. And I think it was 2 years ago now, we implemented a camera in every vehicle policy. Because one of the hardest things to do is resolve a he said, she said. So we think that's improved safety. So, you know, everybody takes that very seriously. Now it's not a foolproof system. And so when you say somebody with a criminal background record is driving, I'm not sure how that happened, but these checks are required. Now, we also require each broker to do spot inspections, because what has happened in the past is that a transporter will hire somebody before they're fully vetted and then put them on the road to transport a main care member before the broker has authorized that driver. So I know that's happened. You know, like I said, the system's not foolproof, which is why we put in these spot inspection requirements. That is to say, a broker can pull over a driver, say, meet me here at such and such a place. They check who they are. They check to make sure they've actually been approved by the broker. And if they've been approved by the broker has documentation that that person has gone through all these background checks. So we're trying to close that one little loophole that a transporter can hire somebody before telling the broker they've hired them. So hopefully this is a deterrent to that.
I'm just really conscious of time. I want to give Michelle a chance. Roger, thank you so much for all of your
Thank you.
insight. And if folks have additional questions, they can reach out to you. Maybe Roger, you could put your contact information in the chat. And I'll pass it over to you, Michelle.
Thanks, Kathy. I'll try to keep remarks brief. I just want to say that we acknowledge how critically important transportation is, and I think we're all grateful that Medicaid provides rides to Medicaid covered services as a benefit, because it would be very, very difficult if that were not the case. I wanted to just offer that challenges everybody's discussing are real, but they're definitely not unique to Maine. They're definitely not unique to ModivCare. Whenever I get together nationally with other state Medicaid programs, non-emergency transportation always comes up as a really difficult challenge. And I will say that when you have a state where we have as high use as we do, as Roger noted, and where also, if you look at statistics around spending on public transportation, I mean, MaineCare is really above and beyond by far the biggest source of public transportation funding in the state of Maine. And so that adds to our challenges as well. And experiences that you as providers have had with workforce shortage, et cetera, has been true for non-emergency transportation. It is definitely not a perfect system. We have lots of challenges. Rachel, I appreciate some of your questions about making sure that members understand how they can easily share when they have a complaint and bad experience that is important. But I do want to give a lot of credit to Roger and his team. I joined MaineCare for the first time in 2011. I was very involved in the CMS concerns and requirements with non-compliance at that time. And comparing our system now to that time, the level of oversight, safety requirements, consistency, data that we have, including, even though again it's not perfect, making sure that we are tracking quality, defining quality. It's almost night and day. So I want to give credit to Roger and to his team that there have been real improvements that have resulted in many members having improved access to the care that they need. Again, not perfect by any means, and we are always looking to improve. And I will leave it at that. Thank you.
Thank you, Michelle. That's helpful background. So again, if you have questions, you can reach out to Roger, and if necessary, we can create more space in another meeting for this conversation. But appreciate the interest and all of the background. Thank you, Roger. Sarah, I'll pass it over to you about outreach.
Yes, Kathy, I definitely will take like 15, 20 minutes on this. And I know that there are other agenda items that are of high interest. So I am willing to push till January if you do want to like keep to the agenda. Because I think there would not be time to get to the other if I were to go.
That's very helpful, Sarah. I appreciate it. Yeah, let's do that. Thank you. And with that, then I will pass it over to the provider subcommittee. Jillian, I think you all met this past month.
Yep. So I looked back and it looks like we're meeting the last Wednesday of every month at 8 o'clock. And I just looked ahead. I've got to reschedule December because I think that's Christmas. So the first topic on our agenda was the MaineCare portal. And I didn't get a lot of feedback from providers on the phone. Some were just listening in. This meeting, we had a total of 5 attendees, which was a pretty good start. I was hoping for a little bit more, robust kind of back and forth with the providers. But the issue that we raised up was just looking into the portal and seeing if there was a way to report the common errors that are experienced. And I know in the past, there's been some sort of training and communication and maybe education around use of the portal. I'm saying we've been here 30 years. We've been using it as long as it existed. And every time we use it, it does not get any better or any easier. And I have 3 people that do it exclusively together every time. And just looking on the inside of it, because there's some frequent errors that we get that provide, you got to do 3, 4, 5 resubmissions for that same error of like attaching a document that doesn't stick, or your license, or, but it keeps kicking back. And I always talk to Ken every time about everything. I just wanted some dig-in information into it to see what's trending in there as errors, and how many providers are experiencing these, and what can be done to try to alleviate them or prevent them, because I'm sure on you guys' end too, it's burdensome. But and just looking that it's a self-service model, that portal, and is that the best model for providers to go in and try to administer it themselves? Or looking at, would it be better if MaineCare administered it, or when we're administering it, we have a rep on the phone helping us navigate the errors that we're getting as we're submitting it. But you know, I think you could probably get through a case in 7 days if there wasn't so many errors that get kicked back. And that's kind of my feedback, just as I sit in when they're doing it, and I get all the kickbacks, and there's a significant amount of kickbacks with even just a simple update. So that's the first raise. The second one was the overview of transportation, which was just completed, and that answered everything that we had on there. The third, we raised back policy feedback, and I'm trying to kind of pull forward where Mallory left off. So I got to dig into if there was anything undone there that I need to follow through, because I'm not quite sure, because I didn't know that I was taking on this role. So I didn't like make notes of like unfinished business. But I know to date, all the policy feedback we've had has been addressed, like the e-signing. I do know we wanted to raise up that sometimes policy related clarification questions can take up to 30, 45, sometimes 6 months to get like final outcomes. And it can be something as simple as, can this provider bill in this service? And it kind of gets raised up, and often 30, 45 days. And then we kind of keep raising it up higher just to get an end result. So just looking at, you know, if it's on the PR or if it got to policy, it's just my management team will sometimes just kick back and say, we haven't gotten this answered yet for that. And then the next one was policy feedback overall of maybe some sort of goal of collaborating in the future, of looking across the different departments of DHHS and starting to look at collaborating on policy. We know the intent that each department has their own policy, but the one that I raised up as significantly burdensome was like PSS supervision. You have it across like so many different entities that we have like 6 or 7 sets of rules that we're following. And we're like double doing and overlapping just to kind of configure to make sure we're getting everybody's rules separately. So just some sort of like future looking at where policies overlap and where they lie, and maybe collaborating across DHHS to kind of simplify policy or eliminate policies or redact, you know, where you can. The next topic, number 5, was the COLAs, and I think that was covered by rate. But the only thing that we wanted to comment on was just communication around COLA delays. I checked with my finance team, and we hadn't been paid for the DHH COLA, and it went into effect, I think, in August, and it was retro to December. And the last communication we had received was in August. So before this meeting and before my provider meeting, I outreached just saying, hey, when can we bill that BHH COLA? Agencies across the state of Maine are looking for some sort of feedback. When can we bill it? Because we got the email, I think, saying we could, and then it didn't work. So maybe just future looking at any value-based purchasing model, probably being a little bit of a struggle with the COLA, just because we can't unattest and rebill like we do with unit billing. So I think COLAs and value-based purchasing just needs a future look to make sure that they pay when you say that they're ready to pay, because we still haven't been paid for that 2023 BHH COLA. And I did ask for an update, and all agencies did get that e-blast that it should be attestable coming in the future and then paid in the near future. It's just communicating if it doesn't, you know, what kind of happened there. And then we talked briefly about service provider codes and service provider tax codes and the history of that. And that again was covered by rates and the impacts we kind of discussed briefly. Number 7, we talked about rate cycles, still looking for, and again, kind of covered in rates too, but we were looking just for that 5-year. I know I've said this several times over different meetings, but the 5-year schedule. When did it start? When does it end? And what years were each rate? So we know what's happened, and we might know a year ahead, but we don't know what's coming or what's left to know if something might have been overlooked. Like I requested during the last rate email from one of these meetings that PSS might, should have been looked at, and it got added, but without seeing that future look of where it ends, I didn't know if it was overlooked or if it was coming, or so just sort of like a timeline of these are what's left, even beyond the year you're looking at. Like, so just looking ahead, even if it just says outstanding, but we want to know, when did the rate cycle start, the 5-year, and when does it end? So we know when to expect the second cycle of rates on set for, fiscal planning and stuff. And then 8, looking at the department offering more training, specifically main care. And, something that comes up is that portal because it's difficult to maneuver. And then maybe communicating the level of the training, beginner, intermediate, advanced, just so it speaks to the person so they know to show up. If it's intermediate, probably not going to be helpful if they've been using it for 10 years. And just some sort of level. So it's at the level the provider's at when they attend the training. Number 9 was OFI, and they covered all of that. And then number 10 was looking for the PRTF timeline to implement, just because the amount of kids that agencies are still seeing sitting in ERs. And I don't know if that got answered, but I know that the answer that I got was it's coming, but we were looking for like, when would that model be in place? Are there any providers potentially that are going to pick it up? I think when I came onto MAC years ago, we sat at a committee and we talked about it. And I think that was like 5 or 6 years ago. It was there on the table. We got to see kind of everything that it involved. And then the providers all said it needs to be better funded. And then, 5 or 6 years later, it's still not implemented. So I think anybody delivering a children's level service is just looking for, when is it coming? Hopefully somebody will pick it up and help kids kind of stay out of emergency rooms. And that was a lot.
Jillian, can I jump in on a couple of those? So regarding, when you were talking about the portal, were you only talking about the portal in relation to enrollment?
Yeah, so anytime you have to say add a new shared living provider, since the HCBS forms got implemented, it's really difficult, and it's almost guaranteed anytime you have a shared living provider, it will kick back, and Laura can tell you it's just problematic. But it's pretty much anytime you need to add a new site or a new service or a new billing provider, a physician, something like that, it's we get numerous errors, and when they look in on it, sometimes they're us, but it's like advancing technology. Like the contracts are manual paper. We have to print them out, sign them, upload them back. And every time we make an edit, if it kicks back 5 times, every time we have to re-update that form instead of just, it's clunky.
Sorry, I just wanted to make sure that you were speaking specifically about enrollment functionality on the portal as opposed to other kinds of functionality on the portal, because there's other kinds of functionality.
Exclusive, yeah, just adding providers, services, locations, that's
okay.
To the level to use it, but
okay. So we have so I don't know if this will help with any of the things you're experiencing or others providers are experiencing. We have on the portal a tips and tricks document. We have I think we have a document that talks about like top provider enrollment errors and how to avoid those. We have shared those with this group over the years. They're still there. We are, as we look to training, setting up our 2025 training schedule, one of the things that we're using as inputs for the training schedule is what are the top issues that we see that providers have with enrollment to inform trainings. I will say that we spent a lot of time trying to come up with what we thought was the best ever training curriculum and schedule for 2024, and found that we had to cancel a lot because people didn't come to the trainings. So it's a little bit of, we do our best and hopefully we are designing a curriculum and topics that are helpful to providers. So we do try to look at, what are the top reasons people are calling provider services? What are the top claims errors people are getting? Denial reasons? What are the top provider enrollment issues and use that to inform training. So we will certainly continue to do that.
I think a real benefit would be, and this is probably a lofty wish just because of time, is like if somebody was available to jump on it with you in real time to help you get it right the first time instead of because we take up Gainwell's time and provider relations time trying to fix a mistake after it goes through rather than having someone help us navigate it when we're doing it.
If you
Because
have a
it's like a
staff member who's right, if you're,
Yeah.
I don't know that it's feasible for us to have a model that, not a self-service model. I'm just thinking, well, it would be a big change and certainly like have big implications for staffing and capacity. But, you know, if you ever have a staff member who's trying to work through real time and you have any questions real time, you can absolutely call provider services and say, hey, I just want to ask these questions or need some help navigating this before I submit to make sure I don't have any errors. So that's absolutely support that provider services can provide while you're going through the case.
Yeah. We do all those things, but it often requires Gainwell involvement and you can't have their phone number. So you got to email and then you could wait days for a response.
But you can call provider
tricky.
services though.
Okay.
Provider services call center is Gainwell and you can call them and ask for assistance while you're going through the case.
Thank you for all that. Let's also just a reminder that we still need ideally a person to volunteer to chair the provider subcommittee. Jillian has kindly been filling in while we've been without a chair. So flagging that along with a vice chair for rates and a vice chair for the whole MAC. Also just want to mention from the dental subcommittee, I know we're short on time, so I'll be quick, but the big issue that we've discussed in our last couple meetings has been a challenge for certain providers, but unfortunately some of the providers who see the most main care patients, who ever since the Change Healthcare problem at the beginning of this year have been unable to submit their claims electronically and have had to do it manually, and it's taking a lot of time for those providers to deal with the challenges related to that. Main Care is aware of the challenges and has been trying to figure out the problems. But it continues to be another stumbling block for dental, which is continuing to try to encourage more providers to take Main Care. So I just wanted to flag that for folks as something that's been a real challenge, and we appreciate all the work that Main Care has been trying to do to figure out the problem, but also it's still a challenge. So we'll probably talk about it again at our next meeting, which is next Wednesday at noon. And if folks are interested in being a part of that group, please feel free to reach out to me. And I'm just conscious of time, so I'm going to pass it over to the rulemaking update.
Thanks, Kathy. This is Jessica. I just have a couple of updates. It'll be pretty quick. Since we last got together, section 43, which was hospice services, we've adopted a rule there, which removes the requirement for electronic visit verification for hospice providers. And then the only other update really is for section 45, we've just filed the rule to make permanent the emergency rule, which was done in August. And otherwise, there's no proposed rules or waivers with open comment periods right now. So it's just a quick update for now. Thanks.
Any questions around the rulemaking piece? Okay, so the last thing I just wanted to touch on was our schedule for MAC meetings. As you know, we have been meeting monthly most of the time for the last several years, but we are going to shift to an every other month model because, as you know, with the new rules from CMS, there is a requirement for stronger Main Care member engagement in the process. And as we've talked about before, Main Care is working on getting the BAC, which is the Beneficiary Advisory Committee, going so that they can then provide more input into the actual MAC meetings. So they're going to be meeting on the opposite months of the MAC, so that those members are able to have a meeting on their own. And then that will help inform what we do with the MAC meeting the following month or over time, depending on what comes up. So we're going to start to make that transition. And I also just wanted to name that we've struggled to try to find a time to do governance work around like to have bylaws for the MAC, and also to have some other just logistical things figured out for the MAC. So we're going to use the December MAC meeting for anybody who's interested in being a part of that work to do that. So you might have noticed that Lisa Weaver, who manages the calendar invite, canceled the December meeting. I'm going to send out a calendar invite to everyone for the December meeting so if you want to participate, you can accept that calendar invite. You don't have to participate in that December meeting if you're not interested in talking about things like bylaws and figuring out the logistics. And then we'll meet as a full MAC in January, and from there do the every other month. There will likely be some other shifts to our schedule in the coming years because, again, of some of the pieces that are required now under this new rule for MACs from CMS. CMS, for those who don't know, is the federal agency that oversees Medicaid. And we'll talk more about that in the new year, but just flagging that change for folks. But again, if anyone is interested in being a vice chair for the MAC, if you're a MAC member, we'd love to have you express your interest. And also, if you're interested in being a vice chair for the rates subcommittee, or a chair or vice chair for the provider subcommittee. Dental has a chair and vice chair, so we're all set right now. Any questions about any of that? Okay. I also sent out an email with some of the links that were shared during this meeting, and I a few more were shared later, so I will capture that as well and share that out along with the slides Roger hopefully can share with us. And so we'll get that out to everybody. But thank you all and have a wonderful rest of your day. And if you haven't voted yet, don't forget, go vote.
Bye. Thank you.
Bye all.
Thank you.